I'm going to ask everybody to take a seat. That's great. Sure.
Say something.
Hello. Hi.
Good.
I want to welcome everybody to this evening's presentation on the Affordable Care Act. My name is Joan Farrow, and I'm going to be your moderator tonight. And I'm very excited about this presentation. We have some fabulous speakers on very, very timely topics, and I personally have been looking forward to hearing what they have to say for several months, so I hope you'll enjoy the presentations as much as I know I will. Before we get started, I want to just mention a couple of housekeeping issues. If you have a BlackBerry, would you please shut it off? It turns out BlackBerries are uniquely able to interfere with AV equipment, and if you get one of those text messages or an email message, it makes a buzzing in the AV equipment. We are recording this and videotaping this presentation for future publication on our website, so we are interested in having the best quality recording we can get. I also, just in case you do want to get onto the web, the site is Wolfie.net Guest, and that is open, and it has no password connected with it if you need to get out there and see what's going on in the world. But if it's in a BlackBerry, don't do it. Ladies and men's rooms is in the hallway behind me. You can exit over by the place where you entered and just walk around and you'll find them. We're going to try to hold the questions until the end. We're at the end of everybody's presentation. There will be an opportunity. We're going to have a panel, and you'll have an opportunity to ask questions. And finally, if you're interested in either CME or CNE credits, please be sure to fill out the appropriate paperwork at the desk when you exit. So, having said all of that, I'm going to show you a picture. Oops, no, I guess I'm not. Wait a minute. There we go. This is President Obama signing into law the Affordable Care Act on March 23rd, 2010. Also known at that time as the PPACA, or the Patient Protection and Affordable Care Act. And did a little research on this because I remember when it was issued, the sort of flurry to try to understand what it all said, and it was published in 906 pages, so I don't know if anybody actually read it. We all waited for our local people and national people to boil it down into some bullet points that we can understand, but it still has lots of ramifications that are coming out. I think that there are many phases to this act and how it gets phased in, and it will continue to be phased in until 2010 and beyond, I believe. But you're going to hear more about the details of that from some of our speakers. I want to take this opportunity to introduce Dr. Pamela Nowak. Dr. Nowak has an illustriously long history in sorry, not long, but an illustrious history. Sorry. Well, it's a lot shorter than mine, so. In hospital administration and both in operations, finance, and strategic planning. And right now, she is an assistant professor in the Department of Healthcare and Policy Management at Stony Brook. And teaches quite a bit on the various strategies and financial aspects of healthcare administration. Her primary research interests are healthcare delivery and comparative outcomes assessment, And the title of her presentation is a brief overview of the ACA. She's going to take us through titles 1 through 10 in a matter of minutes. So welcome to Dr. Nowak.
Thank you. You have to give me instructions on how to use this.
Oh, the right arrow,
Yep.
will advance one at a time.
That's not that.
A brief overview of ACA. So I come at this as an economist, and speaking as an economist, this healthcare reform is about unequal knowledge, because unequal knowledge in our healthcare system causes market failure. Market failure over time has created a situation where people have poor access. Some people have poor access, and the costs continually go up. So as that happens, and then we hit a downward cycle, a recession, we have real tough pressure on access and very tough pressure on costs. As the costs rise, the businesses get upset. As people can't get access to health care, they get upset. And we have a different situation than we have during a positive cycle. So the healthcare reform is presented to the public as looking at ways of solving access, very important, and also trying to take care of some of the problems that businesses have with costs, also very important. We have 10 titles. The first one is really about insurance, and the insurance title is really here to address the access issue. So we have no individual rated health insurance policy starting in 2014. So if I'm high risk, I can't get a higher rating than you, and I can't be forced to pay thousands and thousands of dollars for my insurance. Most Americans need to obtain insurance by law, or they pay a penalty. Financial subsidies are going to make it possible for everybody to have insurance. State and federal one healthcare exchanges are right now being set up, and I think many of them will be state-run, but many of them will be federal-run, and a few of them will be shared. No lifetime annual benefits for limits. So if I'm chronically ill, I don't run out of my benefits after 20 years. If I get really bad cancer and I'm treated 3 times, I don't run out of my benefits. And children age 20 up to 26 can be on their parent policies. And this started in 2010. So this is to alleviate some of our immediate access problems. Title II looks at the public programs and also really looking at access. It's improving its intent was to improve the Medicaid benefits and standardize them for Medicaid beneficiaries. However, the Supreme Court did strike down the ruling that all the states had to improve their benefits packages for their poor to raise their ceilings, and it also does require mandatory quality improvement. So it's, again, expanding financial access. That was the intent. Title III looks at improving quality and efficiency, and if you look at the goals, effectiveness, efficiency, and patient-centered care, you really have the AAA, and added into that AAA, you have a little bit of focus on getting the patient engaged. That third one, patient-centered care, talks about maximizing population health and getting the patient to be the agent of change. So it's the AAA, but let's look at the patient and get the patient engaged. And some of the things that the title talks about are increasing preventive benefits and then going out and trying to get the patients to use it by not making them pay, reducing the donut hole. That's the Medicare drug thing where after you hit a ceiling, you don't get any drug benefits for a while. And what that does is it helps get access to vulnerable populations. And for the cost, we reduce Medicare spending by $450 billion over 10 years. This Title IV, I think, is a continuation of this AAA kind of thing. It's really aimed at chronic disease and public health. There's a national workforce, did that wrong. There's a National Prevention and Health Promotion and Public Health Council that will be established, and it's been funded with $13 billion trust fund. Insurers are required to provide evidence-based preventive services, but we don't really know very much about what those are going to be yet. And restaurants are required to post calories on their food. So here again, we're looking at, well, there's a lot of information inefficiency, and these are our ways of addressing information inefficiency, and also dealing with provider moral hazard that I treat when it's acute, but I don't treat when I can prevent it. There's a workforce bill, Title V. We want to establish a national workforce commission so that we can analyze what our new health force will need, because we don't know what it needs, and we probably don't have the right types of employees in the labor force right now. Particularly, we want healthcare to be community-centered, so we want community health center funding, and we want different types of labor that can function in the community. So in addition to primary care, we are looking at training community service workers who might be going and making home visits to communicate with patients somewhere in the continuity of care. We need care coordination. We don't have a lot of care coordination, so that would be training new nursing people to do care coordination. And also, we're really looking at changing the role of nurse practitioners and physician assistants in delivery of care and allowing them to do much more primary care services. In terms of transparency in the program, again, transparency is about information. So if we have a good program and it's financially transparent, then we reduce fraud and abuse. We require public reporting of gifts to suppliers and from suppliers so that pharmaceuticals can't send all the doctors to Tahiti and give them a really good time and then they buy their drugs. That would never happen, right? Establish a patient-centered outcomes institute as a public-private entity to support clinical outcome research. So here we're talking about being able to see what interventions, what treatment interventions actually work, and documenting that, and then turning to those as the correct care for patients who need them. And there's a long way to go on this, but there is this institution out there, and it is active now. Nursing home transparency regulations and Elder Justice Act, particularly to fill knowledge gaps again, and knowledge gaps for our most vulnerable population, who are the elderly and the poor. Improving access to medical innovative therapies. The FDA instructed that they wanted a pathway developed to get biopharmaceuticals, a generic-like biopharmaceutical marketed. So more access to medications at lower costs. Try to address the anti-competitive efforts to keep generic drugs off the market, and provide discounts to hospitals and communities serving low-income patients for pharmaceuticals. I don't know that it went far enough to solve the market problems that surround the drugs, our pharmaceutical pricing, and I think we just had some recent backlash on that with the sequester and the impact of physicians who were doing chemotherapy in their offices. A lot of them are saying that they can't really afford to do the top end of that because of the cut to their reimbursement. Title VIII was supposed to talk about long-term care insurance, but it's been abandoned, so we don't really have to talk about it. Title IX talks about revenue provisions. So this is kind of a funding bill. There's going to be new Medicare taxes levied on high-income wage earners, new taxes on corporations, and we have a list of them. And again, so this is the idea that those who stand to gain from the bill, if you're in the pharmaceutical industry, if you're a healthcare provider, of course you're going to gain from the bill. So then there are some taxes levied on you, and that's where they're going to come from. And then there are taxes, kind of sin taxes. So for some reason, a 10% tax on indoor tanning salons. That's a sin tax. unless they had the Title X, Quality and Affordable Health Care for All Americans. This was the act that kind of enabled the legislation to exist and tied it all together. It does have some reauthorization of Indian Healthcare Improvement Acts and some other miscellaneous rules, but I think it was more there to enable a final resolution and reconciliation. And that's my brief summary of the Affordable Health Care Act.
Thank you, Dr. Nowak. So with all of that to get done, no wonder it's going to take us to 2020 to roll it all in. And be interesting 7 years from now whether we'll see it all happen. Dr. Kathleen Schur is going to speak to us next. She's currently at the Greater New York Hospital Association. She's a senior vice president, and she's involved in health reform policy matters that involve coverage expansion. She has previously worked at the Department of Health in the Office of Managed Care at North Shore LIJ and the Management Services Organization and at HIP as a senior vice president of provider relations and government. Kathy's going to speak to us about healthcare exchanges and how they're going to be implemented. Many people are wondering what they are. They also wonder how they're going to work and kind of timeline and what it's going to look like in New York State. And I think Kathy's going to help us understand all of that. Thank you.
Thanks. Hi, everybody. So Pam gave you, a broad overview of everything that was in the Affordable Care Act. Much of that has actually already been implemented or is in the process of being implemented. What I'm going to do is focus on some of the really big changes that are going to kick in 2014 and some of the things that people automatically think about when they think about health reform. Those things are mostly going to happen in January of 2014. Okay, so starting in January, there are 5 major pieces that I want to talk about. So first of all, as all of you know, there's a requirement in the ACA that individuals have health insurance or pay a penalty. That begins in January. There's also a requirement that employers, if you have more than 50 full-time employees, you must offer adequate insurance or be subject to a penalty. Medicaid income eligibility is expanded. Originally it was supposed to be expanded across the country to 138% of the federal poverty level. Now that has become optional for states, but most states, I don't think it's the majority yet, but close to half of the states have already decided that they will implement the Medicaid expansion. And then the things that make all this possible is that there are subsidies that will be available beginning in January for people that earn up to 400% of the poverty level. And we'll talk about what that means later. And there are also tax credits that are available to small businesses, to certain small businesses, that will reduce the cost of coverage to them. And those last 2 items, the subsidies and the tax credits, are only available for coverage that's purchased through the health exchange. So what is an exchange and what does it do? Well, you can think of an exchange, that's only a part of it, but the visible part to the public. You can think of it as an online marketplace for insurance, kind of like Travelocity or Expedia. You'll be able to put in certain basic information about yourself and then be able to determine what options for health coverage are available to you. You'll be able to compare plans, their benefits, their costs, your out-of-pocket expenses. All of that is supposed to be available through this online marketplace. But the exchange also has to do a number of other things. So the exchange, first of all, will determine which plans can be sold on the exchange. They'll make sure that those plans provide all of the essential health benefits that are required under the law to be provided. They'll provide a toll-free hotline, make an internet website available for enrollment. They will also establish an electronic calculator so that you can try and determine which plan is best for you in terms of your out-of-pocket expenses and the providers that you use. They will also importantly determine eligibility both for the subsidies of the exchange and for the public programs. Because if you think about it, there's sort of an arbitrary line. If you earn under 138% of the poverty level, you're eligible for a public program for Medicaid. If you earn above that, you're eligible for a subsidy. And they want to have like a one-door policy so that anybody can go there and find out what, in fact, they are eligible for. They will also be establishing a navigator program, and that is a program for, gets to be fairly complicated, so in order to properly inform people about what their options are and help them choose the one that's best for them, there will be navigators to assist them in the process. And then lastly, there's other things they do, but the key one here is that they will certify individuals as exempt from the mandate or subject to the mandate. So let's talk a little bit about what those mandates are. So beginning in 2014, as I mentioned, there are mandates on employers and mandates on individuals. For employers, it depends on whether you're a small business or a large business. If you're a small business, which is defined in this year as up to 50 employees, the states had an option of going up to 100, but New York has chosen to do it just up to 50. In 2016, it will go to 100, and in 2017, states have an option of bringing large businesses in. So anyway, if you're under 50 employees, there's no requirement to offer insurance, so if you don't offer insurance, there's no penalty. For large businesses, defined as 50 or more full-time employees, and full-time is defined as 30 hours per week, the requirement is that you have to offer adequate insurance or pay a penalty. And the penalty is equal to $2,000 times the number of full-time employees minus 30. Now, the penalty only kicks in if one of your employees accesses subsidized coverage in the exchange. So if nobody goes into the exchange and gets a subsidy, you don't have to pay a penalty. Important here is also is that you have to offer adequate insurance, and that's defined roughly as covering about 60% of your medical costs. If you offer coverage but it's not deemed adequate, then you're also subject to a penalty, but the penalty is less than what you would pay if you offered no coverage at all. Okay? For individuals, the requirement is that you, if you don't have access to affordable employer coverage, you must purchase coverage on your own or pay a penalty. You can be exempt if the amount that you would have to pay out of pocket towards your premium, less the subsidies, exceeds 8% of your income. So the exchange, again, will determine whether or not you qualify for what's called an affordability exemption. And the penalties are really fairly moderate, especially in the first year. It's $95 a year for an individual with a family maximum of $285 in 2014. But they do go up. In 2016, the family maximum penalty is $20,085 if you don't have coverage. Okay, so the way the subsidies work on the employer side, if you're a small employer of under 25 and you provide coverage, you may be eligible for a tax credit. The tax credit could be up to 50% of the cost that you're paying for coverage, but it only applies if you have fairly low income workers. So it applies if you have less than workers with average salaries of less than $50,000 a year. On the individual side, subsidies are available for people earning between 100 and 400% of the poverty level. And it basically, your contribution to coverage, everybody has to pay something towards their coverage. Your contribution is based on your income. And the subsidy then is the difference between the premium, and it's the premium for the second lowest price plan in the exchange, and your required contribution based on your income. So just as an example, for a family of 4, on the bottom there you can see what the federal poverty levels are. That's for an individual, it's just over $11,000. For a family of 4, it's $24,000. The way the subsidy works is that if you earn about $32,000, that's at the low end for a family of 4. That's at like 138% of the poverty level. You'd be eligible for a subsidy of over $12,000, and that's expected to cover about 92% of your premium cost. At the high end, so a family of 4 earning $93,000 would still be eligible for a subsidy, but it's much lower. It's about $4,000 and would cover about 33% of the premium cost. And there are you can go on the Kaiser website, and there are calculators where you can put in different numbers and figure out what the average subsidy is going to be. So everybody's required to, the states are required to set up an exchange or default to the federal government. Most states at this point are defaulting to a federal exchange, and that's partly because, I remember all the controversy about setting up the exchange. People were first waiting for the Supreme Court to decide whether the health reform law would go forward. Then they were waiting for the election. By the time all of that happened, even if you wanted to set up your own exchange, for most states, if you haven't been working on it, there wasn't enough time. So right now, I think there are 17 states that are setting up exchanges. That may change in the future, so it's not a permanent decision. You know, a state can decide in the future that they want to do an exchange of their own. New York State decided it would do an exchange, and the governor last April, by executive order, established the exchange within the health department. And this is sort of the timeline from then going forward. In January, the exchange sent out a solicitation to health plans inviting them to participate in the exchange and telling them what some of the requirements are and what some of the standards were. The plans last week was the due date for them to submit their products, their premiums, their networks. All of that was due last week. Between now and July, the state will be reviewing that. The exchange reviews it, the insurance department reviews it, and the health department reviews it, the networks. So all of that's going on right now. Hopefully will be concluded by July, at which point the exchange will announce which plans are going to be participating in the exchange. Then it's planned that an advertising campaign will kick off in September, and on October 1st, the exchange is supposed to be up and running. So an awful lot of work underway right now. For once the exchange is open, people will be able to enroll. Coverage will begin in January of 2014. Now, the other thing that's important to note is that there will be an open enrollment period every year for the exchange. So it's not like you're going to be able to go anytime and purchase coverage. The open enrollment period this year, I think, goes through March. It's a little bit longer. But in the future, it's expected that the open enrollment period will be just October through December. And that's important because, you know, there has to be a defined time period. Otherwise, people could just wait until they got sick and purchase coverage then. So what is this all going to do in New York? Well, the state engaged the Urban Institute to model exchange implementation and health reform implementation in New York. And the anticipation is that about 1 million people will gain coverage when health reform is fully implemented. And you can see that about half of that is through Medicaid. And interestingly, you know, New York has a very comprehensive Medicaid program. The only expansion that will happen in New York is for childless adults between 100 and 138% of the poverty level. Because we were covering parents up to 150%, we were covering children up to 400%, and we were covering childless adults up to 100%. So we have a very small Medicaid expansion. There's only about 70,000 people that are expected to gain coverage because of the expansion. The rest of that 500,000 people, those are people already eligible for Medicaid that aren't enrolled. And they're expected to enroll because what they call the woodwork effect, with the advertising campaign, with the navigators, with all the outreach, people that are currently not enrolled are expected to choose to enroll at that time. And so that million people is a little bit different than the million people that are also expected to enroll in the exchange. Because remember, Medicaid really is not an exchange product. People will be able to determine if they're eligible for Medicaid through the exchange. But the people that will enroll in exchange products are not Medicaid eligible. They are individuals purchasing coverage directly on their own, and also small businesses who can purchase in the exchange. So about 558,000 are expected to be individuals purchasing coverage. 413,000 will come from, 413,000 are individuals with employer coverage, and the 558 are purchasing directly. That is expected to, both of those things expected to reduce the number of uninsured in New York from 2.6 million to 1.6 million. But one thing that's sort of interesting when you look at the exchange, and we tell our hospitals this all the time, many of the people that will be purchasing coverage in the exchange were not previously uninsured, about half of them. Half of them are going to come from existing products. So people need to think about that as they're contracting, because there's going to be a lot of movement, people moving from small group coverage to individual coverage, and people going back and forth between Medicaid and individual coverage. So this is going to be very fluid, and a lot really is at risk depending on how you contract. That's it.
Thank you, Kathleen. Next, we're going to hear from Jay Schoenfeld. Jay is the Director of Government Relations for Emblem Health, and his topic is the impact of the ACA on private insurance. And given what Kathleen just told us, I'm interested to hear how the private insurers are looking at this entire landscape as it changes. So welcome, Jay.
Thank you, Joan. Thanks for having me. Before I start, I just need to say that even though I work for Emblem Health, it's kind of my official disclaimer, I am speaking for myself as someone knowledgeable about insurance. Anything I say is my opinion, not Emblem Health's, and we can talk more about it later. So I just want to get that out of the way. I was at a conference one time in Washington, and some columnist came and spoke to us, and it was an insurance trade association kind of thing, and he said, essentially what you guys did is you traded more regulation for more customers. And I never thought about it that way, but in a sense it's true. You have varying state to state policies differ, practices differ tremendously, and one of the things the Affordable Care Act is going to do is have some sort of common framework about similarities, or some standard rules for insurance. States are still going to be allowed to do some things differently, but there's kind of a common ground framework that you all have to fit in. Okay, there we go. So one of the things the Affordable Care Act did is it changed a lot of the rules around insurance, and these are Pam talked about a lot of these, and they've, for the most part, all taken effect already. New York, in a sense, was more, call it progressive, if you will, that it had a lot of these things before the Affordable Care Act. Some it didn't. Just to talk about, for instance, community rating is really, really important, or what they call adjusted community rating. Right now, only 8 states. Community rating is basically when you charge everybody the same price. Most states do what they call underwriting, which if you have life insurance or homeowners insurance, it's kind of based on factors unique to you. And so if you're sick, you pay more. If you're healthy, you pay less. Younger, you tend to pay less. New York has what they call pure community rating, so everybody, regardless of your age, pays the same. Many states do adjusted community rating, but even in the Affordable Care Act, they let that stay, but they narrowed the range, the variation, if you will, that you can charge. You can charge a younger person not as much less, and an older person you can't charge nearly as much more than you used to. So some of those things are going to be, you'll hear about some of the sticker shock that's starting to happen in other states. It's largely because of community rating and the changes in that. Also in the Affordable Care Act, they establish minimum loss ratios or net expense ratios that insurance companies have to spend a certain amount of the premium on insurance and related quality and matters that improve quality. New York had a law like that already. It's actually 85% for large groups, 82% for small groups in New York. Also, the Affordable Care Act essentially gives states, or actually the exchange, what they call rate review. And if someone deemed your rate unreasonable, which they did not define, they could preclude you from participating in an exchange. New York had already passed a similar law, which actually gives the superintendent broad authority over rates, and I'll come back and talk about that later. So, like I said, most of these things already exist in New York, and so there'll be a lesser impact than you may hear about in other areas of the country. In the Affordable Care Act, one of the frameworks they decided was there should be essential health benefits that every policy should cover, and they established 10 categories of care, including doctor visits, inpatient hospital care, outpatient hospital care, drugs, mental health. Not going to name them all, but at the same time, they allowed the states to determine what, for the time being at least, what that essential benefit plan will be. In New York, and they gave you a formula of how to do it. You could pick among the 3 most popular plans offered to federal employees, offered to state employees, sold in the small group market, and the largest HMO in your state. New York chose the Oxford EPO plan, which is the most popular small group plan. And it will, even though it's a fairly comprehensive plan, it will include new services that were included in the essential 10 categories of care, such as habilitative care. You heard of rehabilitative care. Now insurance has to cover habilitative care as well. Pediatric dental and vision are some other things that a lot of policies don't cover. So there will be more benefits going forward. And then what they also said is that mandates, things that your insurance has to cover, if they were enacted by December 2011, then they will be eligible for subsidy in the exchange. One of the things that people always complain about insurance rates, but the rates come, but no one objects to when you get more coverage, and there's a trade-off there, and people have to decide it. So in the future, if the state passes additional mandates, they will probably not be eligible for the federal subsidy, which would mean that the state would have to pick up those costs in some manner. People wouldn't get the subsidy for those additional benefits. One of the important things that I just need to explain a little bit, it's called actuarial value. And that is essentially the percentage of a population's expected health cost that will be covered under insurance policy. And you probably heard about the metal tiers, and that's how they set this up in the exchange. Bronze will be like the base policy. There will be what they call a catastrophic plan for young adults, but for most people, these are the general categories. And the premiums will be, prices will be, the more benefits your policy covers, you'd expect to pay more. The federal government also established an actuarial value calculator, which you have to run all your plan designs through, and you have to be within plus or minus 2% of those targets. And this is so that plans are kind of using a common methodology to come up with your prices. And then the subsidies, as Kathy mentioned, are based on the second lowest cost silver plan. So, as we talk about the exchange, it's a sort of a new way to buy insurance. Right now, the numbers that Kathy put up are kind of indicative of how much opportunity there is out there for in a business that's this is a new market and there are new customers. The state has right now what they call a very limited market for individual insurance. Essentially, there was it's holdover laws that the state has been unwilling to change, but there is one, because they expected most people to get coverage through their employer. A lot of people who did not have insurance were also unable to work, and they were unable to work because of illness, and the state established a plan that would cover those, very generous benefits called the Individual Direct Pay Plan. Governor's Bill it's referred to. And because of the benefits are rich, it's very expensive, and because it's expensive, a lot of people don't buy it. We have right now no guarantee, we have no mandate to buy insurance, so it's optional. So what happens is the healthy people say, I will take my chances because I don't want to pay that much money, and the people who need the insurance buy it. And every time that happens, because there's more claims compared to premium, the prices go up, and more people to say, well, maybe I'm not that sick. I can get by without this, or I can't afford it anymore. In insurance terms, it's not a pretty name, but it's called a death spiral, meaning fewer and fewer people paying higher and higher premiums. So right now, the individual market in New York consists of about 30,000 people, and we're here talking about maybe 500,000, 1 million, coming into the exchange. So that's really exciting, and it's a lot of opportunity. The state trying to, as they create this new market, they're trying to equalize a lot of things. They want to equalizing risk is really, really important from an insurance perspective, so that plans get a fair distribution of healthy and not healthy customers, that plans don't do things that will maybe not, that will preclude them from getting their if you will, fair share of unhealthy customers. Generally, people who've looked at, large populations will see, if you look at the health of a population, you'll see sort of a bell curve. Most people within a reasonable health status, varies based on age, some other factors. And then off to I'm not sure which way I'm facing here, or which way you're facing, but off to one tail, you'll see a very few people who are just so far out, and they have just tremendous health costs, comorbidities, heart disease, diabetes, emphysema, a whole bunch of things, mental illness frequently too, and And the studies have shown that maybe 2% of the people, or depending on what you look at, 2% of the people maybe consume 20% of the healthcare, or maybe it's 5% consuming 40%. It's fairly skewed. So 20/80, okay. The good old 80-20 rule, when in doubt. So thanks, Kathy. But so they want so no plan wants to get stuck with all those people, and so they're putting in a lot of rules to make sure there's equal opportunity and for everybody, and that it's spread around. So the state, because of the federal regulation on established a maximum of 7 rating regions per state. Rating regions is where you take whatever factors you use about your population to set a price for everybody in that region. And what they said, and people said there should be more, and maybe there will be in the future, and the state said, we could appeal this for you, but even if we win, you won't have time to do all your filings, so let's go with 7 for now. So everyone said, okay, fine. And what they said for the exchange, plans can participate in the exchange, not in the exchange, but what you have to do is if you're going to go in, you have to be in all the counties that you're licensed. Now every plan, for whatever reasons, has a different licensing structure. In New York, you license county by county for the most part. So they said they don't want the health plans to pick, a county that they think is good versus a county that's not good. So they said you're in everywhere or you're not in. Then they said we're going to have a state-developed standard product at each meta level, and you can offer, to help make it easier for consumers, you can have up to 3 non-standard products that you can design your own. Is anybody familiar with the Medicare system that offer enrollment, or anyone help their parents try to enroll in Medicare ever? Well, if you go onto that website, Pam's giggling, it's, you go there and you put in what your county, and they come up with, 75 choices. And, I'm in insurance, it's hard to do. Forget about, having to help my mother do it. It's, So they want to make it easier for consumers. So they said that's what you can offer in the exchange. Out of the exchange, you can offer whatever you want, but in the exchange, up to 3 products per meta level. Then about a week and a half ago, they said, well, they saw that plans were, because they expect most people to want bronze plans, they're offering more bronze plans. And they said, well, we don't want everybody having only bronze plans and just offering standard other options. So they said, kind of changed the rules a little bit. They said, well, you kind of need to offer the same amount of products or offerings across all your meta levels. They said, we'll give you 1 more in the bronze if you want, but you can't offer like 4 bronze plans and 1 gold plan. So they threw that on us like literally about a week and a half ago, and they said, all right, if you need to adjust your filings, we'll give you another couple of weeks. So they're doing that. And then the most important thing everybody should understand is that they've actually defined what a product is in New York. It's going to be a set of benefits, cost sharing, that what portion of the cost you pay versus what the member pays, and what your network is. And so when you do your 4 products, you can have the same benefit and cost sharing with 2 different networks. You could have, same network with 2 different cost sharing options. You can, up to 4. But that's kind of what the rules are. Some of the rules for the exchange. Kathy talked about the timeline. So plans have until, the big issue, plans got most of their stuff in, unless you needed to adjust your product offerings because of this new rule. The rates that the Department of Financial Services grants are going to be very important to determine whether plans decide to participate or not. As I mentioned earlier, the Department of Financial Services kind of has absolute authority over rates right now. So if plans are waiting to see what the rates are, if you got what you filed, then you'll go into the exchange. But if they gave you a rate that you don't think you can survive on, then you may not go into the exchange. And then you left some time for some back and forth between plans. And then the rest of the timeline is what we have there. So some of the other rule changes that they had to make, because we were talking about this before the panel, and there are different rules for insurance, whether you're an HMO, a point of service, and Article 42, 43, 44, and they're really said for this to be equal and to even things out and to not advantage or disadvantage certain products, certain lines of business. They said you can kind of file whatever you want to in the exchange. They are in the process of, I think they've made a lot of progress on equalizing some of the rules, whether it be about broker commission, about networks, and some things like that, quality reviews. They said that if you offer a product on the exchange, you need to offer it off the exchange as well, so people who are not eligible for the subsidies can also buy it, because they want that risk to be equal. They've also established greater clarity between the individual and small group markets. I talked before about what the individual market was, and you got a lot of people in business for themselves, sole proprietors, people who are technically individuals, but obviously capable of working and don't need all that insurance. The state has allowed over the years associations, and either they get them through businesses, through chambers of commerce, some trade associations, and associations pay closer to group rates than they do the individual rates. So they've said, and that's part of the federal law too, they've drawn a very clear line on what's individual, what's small group. So all those associations are going to be now considered individuals. Sole proprietors are now individuals. The state is phasing out some of the products that we now know. The individual direct pay, I talked about Family Health Plus, which was kind of covered people above the Medicaid level, and Healthy New York, which was established ostensibly a long time ago as a lower cost, lesser benefit option to traditional health insurance. The asterisk is because for now, the state is keeping that around for small groups, although they're not subsidizing it anymore. So it probably only last another year, really. And actually, the traditional Healthy New York product has already been frozen, so that'll probably go away too. Big adjustments in how the risk adjustment mechanisms are that will equalize the risk of some of those people I told you about, which I'm not going to go into now, and more changes to come in the future. You might have heard of something called the Basic Health Plan. The federal government basically said, and that was to cover I'll explain it briefly. It would cover the people up to 200%, between Medicaid and 200% of the family poverty level, with a set plan, and people would not have to pay. Individuals would not have to pay a premium. So the state would trade off some of the subsidies that you would get for putting those people in the exchange to give you enough money to run the basic health plan. The federal government just basically couldn't get the regulations set up in time, so they're going to come out with them maybe for 2015. The state kind of looked at it a little bit. Urban Institute, no, it wasn't Urban Institute. Somebody else did another study.
It was Urban.
Was it? I thought
and CSS too.
Community Service Society. Okay, I didn't realize they were both on it. And what they kind of said was, well, if things go right, you may make a little money on the insurance aspect of the basic health plan versus getting a subsidy for those people in the exchange, but the state could get up to $500 million by covering people who are not eligible for Medicaid in that. So basically, non-citizens and people here legally who are not eligible for Medicaid. So the state is looking very hard at that, and I would expect you'll see that in the future when the regulations come. And then the other thing that was talked about already is the eventual change in, expansion of the small group market to include up to 100 people. So that will change some things further. We talked about the uninsured, and where most of them are under 200% of the family poverty level. And what was interesting is that a study came out a few weeks ago that Deloitte Touche did a study. They looked at some other studies, and they kind of concurred and added some of their own experience, that the uninsured are actually less healthy than the insured people at each age group. However, because the uninsured are predominantly younger, they're likely to be healthier overall. And I think you'll see, as the uninsured come into the exchange, you'll see some pent-up demand for medical care. Just a couple of things to think about, and maybe we'll get back to these in the discussion later. This is kind of an oxymoron, but I'm an insurance company. Healthcare spending is kind of what we do. Consumers complain about healthcare spending. Those of you who are on the provider side, my healthcare spending is your income. So there's always that give and tug. Prior approval of premiums, I kind of talked about some. I'm not sure that's helpful for providers. What I think it means is that if you look at the amount of health care that government pays for directly through Medicare, Medicaid, covering federal employees, it's in the, I'm not sure the exact percentage, it's in the low to mid-50s now of overall healthcare spending. Now with prior approval of premiums, government, although not the same government, has control of the amount of spending that it does not do directly. So government essentially is collectively setting whatever the healthcare budget is for our society. I'm not sure that's a good thing. In terms of payment, model, you'll hear more about that in a little while. You're going to see a movement away from the fee-for-service model and what I'll call sick care. People get sick, they go to the doctor when they get sick. I think for providers, you should expect to see greater transparency. Health insurances have gotten used to it. Hospitals are slowly coming around, and I think individual providers, it's going to be interesting to see how everyone responds to that. This will include fees, quality, different things like that. And I think providers need to kind of work to the top of their license. We have a lot of debates in the legislature now. Nurse practitioners, whether or not they should be able to issue death certificates or give school physicals, and the doctors are opposing that, and it's kind of it's kind of silly if you ask me. But my last and some practical considerations. Just this is new for everybody, so there'll be a tremendous learning curve. For a lot of people in the exchange, they could be paying in an insurance product one month, in Medicaid the next. So cost share and copay, it's all going to change. It could change visit to visit, and it's not. I don't think it's going to go smoothly right away. I just don't. I expect lots of reconciliation. As we all have to learn to adjust to the rules, learn to the new systems. So it'll be, people just need to dampen their expectations a little bit. Thank you.
Thank you, Jay. Very interesting on the practical considerations, I think. Sort of like what someone I know calls a payment experiment. We're going to have a payment experiment for the next several years. Dr. Nowak is going to return to us for her second topic, and that is to address the question of what is an ACO. I think that is the mystery question, in fact. Everybody has a different explanation as to what an ACO really is or how it works, and I think Dr. Nowak is going to shed some light on that for us. Thank you.
I have my opinion on what an ACO is and how it works. So that's what you'll hear. To begin with, I think that from the perspective of Medicare, I think this quote from Donna Shalala kind of describes what CMS thinks of when they think about an ACO. They want people to get their care at the right time and to see the doctor early before the problem turns serious. So right time, right location, right provider. We go to CMS, we ask them what they think of an ACO. It's a group of doctors, hospitals, and other healthcare providers, and they give coordinated, high-quality care, the right care at the right time, and they'll share in the savings achieved from the Medicare program. So if you give care at the right time and it's coordinated, and the right providers are giving the care, then we're going to save money. That's the philosophy, and that's an ACO. So Medicare has some ACOs. They have shared savings ACOs, which are I think the most common. Those are primarily fee-for-service, less risk sharing. Advanced payment ACOs, which are targeted at rural providers and small practices that want to get into the ACO business. And the idea there is that Medicare actually pays them in advance, gives them some financial support in advance so that they can invest their capital and get their ACO going. And then there's Pioneer ACOs, and those are primarily risk-based. They have a much higher risk-sharing requirement for the providers that enter those. To be in an ACO, a Medicare ACO, you have to agree to manage the healthcare needs of at least 5,000 Medicare beneficiaries for 3 years. And the providers are able to share in the rewards if they reduce costs while achieving their measures on the 33 quality targets that they have to report on. So if they don't reduce the costs or they don't meet the quality standards, they're not going to share in the rewards. But if they do, they will. For Medicare, ACOs can be run by a hospital, by a community health center, a rural health clinic, or a physician. They can't be run by an insurance company. I'm not really sure why. Insurers can be members, but they're not allowed to run them. Many of the ACOs are currently run by hospitals because of the need to access capital. So hospitals often have more capital than other organizations, and so they're putting up more capital, and they're kind of driving the formation of some of the ACOs. Insurers are entering the ACO private market, and often the insurers are running ACOs in the private market. And when they do, they have a really important advantage in terms of tracking data and really doing the risk management because they have these capabilities. They've been managing the data for a long time. They know what they're doing there. There were a lot of legal concerns in terms of getting started with the ACOs, and when Medicare originally put out some requests for proposals, I guess we'll call them, for ACOs, a lot of providers didn't respond, and part of the problem was that they were concerned about the antitrust implications from the Sherman Act and the Clayton Act and anti-kickback regulations, and they were reluctant. The requirements were much more rigid initially than they initially were, but the Department of Justice and the FTC ultimately agreed to a per se illegal, not challenges per se illegal, an ACO that negotiates in the private market. So instead they're going to use a rule of reason analysis, provided that they comply with the CMS standards. And what that does is it allows providers to move towards getting an ACO without having a required review of their proposals of who's going to be in the ACO and what the agreements are going to be. It doesn't negate that they will ever be reviewed. If the FTC wants to review them, they can, but they would do that on a rule of reason basis. They'd only do it if they thought that there was a reason to do it, I guess that means. They'll apply an antitrust safety zone if the ACO has 30% or less of common services in the primary care area. So again, that gives you, if your market share isn't more than 30%, you're kind of in a position where you can go forward without too much worry, although I wouldn't say that you could go forward with no worry. So that has improved the situation, and there are different providers going and trying to become ACOs. How are they doing? Well, as of October 2012, there were 318 ACOs in 48 states, with 25 applications under review, according to Myers. And 126 were public payers and 31 were both. So Medicare was reaching, and a Forbes estimate in 11/26/2012 said the Medicare rate reached about 10% of their recipients with their ACOs. Mostly they were fee-for-service, not a lot of risk-taking. And Medicare actuarial savings were projected at less than $1 billion over 3 years, which is 0.1% of the total Medicare spending for that time period. So that's not a huge amount of projected savings. It's a small amount. However, the ACOs are in infancy, so we could hope that over time we might see more savings as people get used to doing the risk management and get more involved in the data analysis. In terms of staffing, many hospital ACOs are going out and hiring physicians, but there are a lot of independent practitioners that are increasing their affiliations with ACOs, either joining without being acquired, and there are a lot more independent provider organizations that are becoming ACOs. ACOs tend to hire a lot of care coordinators, RNs, and MPs, ratios around 1 to 350 patients. They can go like 1 to 200 if they're dealing with a lot of higher risk chronic ill patients. And there's a tremendous need right now for more IT functionality and being able to warehouse data and then data analytics. There's a real strong need for data analytics. Some questions and challenges for Medicare ACOs. Will CMS be able to provide timely data to support the needs of the ACO startup? So I want to start my ACO, I need to understand the risks of my patient population. I probably don't know exactly what my patient population is because of the way that it gets assigned by Medicare. So am I going to get this information from Medicare? Is it going to be meaningful enough that I can make any kind of assumptions on what my costs are? That's a really important question. How can specialists and competitive markets participate? According to Medicare, specialists can join one ACO. So when we think about that, if a specialist is looking in a metropolitan area, they may be involved with many different systems providing referrals to many different systems, though the primary care may split up very differently. Specialists may be looking at, well, where do I want to go? Do I want to join an ACO because I got to make a commitment to one? So that's an issue for physicians. They may be part of large group physician practices, which may solve it somewhat. I think the very big question is the clinical financial risk management. On one hand, Medicare wants a lot of freedom for patients, so patients who go outside of the ACO aren't penalized. So what that does is it gives me license as a patient to use my ACO services when I want to, but if I'm feeling that I'm not getting the right service in my ACO, I'm allowed to go out and shop around, and now the ACO is going to lose knowledge and control of where I'm shopping. So I really like my primary care doctor, but now I have a neurology problem, and I don't really like the neurologist in the ACO, but I do like the neurologist in that system over there, and I go off and I use that system. And the system where my primary care doctor has me as the ACO, I'm over there getting medical care in another system. They don't know it. They aren't getting communication about it. They're incurring the costs. The costs go to the original ACO in terms of looking at Medicare and in terms of looking at provided benefits. So that seems to be an issue to me. It's really tough. So minimally, we need a lot of patient education and provider education and patient engagement. If I want to keep these people in my ACO and my program, I need to get them engaged in thinking that I'm the right system provider for them and that they don't want to go over to the other system. And patients, generally, I don't think have been engaged that way by the systems that currently exist in our area. There's also a reimbursement shift from inpatient reimbursement, fee-for-service, the toxic reimbursement that we all hear about on the news, to outpatient reimbursement, on community reimbursement. We want to get more risk reimbursement. We want more capitation, more bundling of services. We don't want to pay fee-for-service, and we don't want patients in the wrong place. The wrong place is the most costly place, the hospital. If I can get this service in an ambulatory care unit, I shouldn't be getting it in the hospital. It costs more money, more capital, more expensive to get it in the hospital. That's what we're pushing for with ACOs, get it in the right place. That means the least costly place that the quality care can be provided. So that's what we're looking at. So reimbursement shift, less reimbursement for higher institutional care, perhaps more reimbursement in the community because we want the care to shift to the community. And reimbursement needs to decline, because if reimbursement doesn't decline, we don't save costs. We don't have a reduction in cost unless reimbursement declines. These are big challenges. If I'm on the hospital end, I don't particularly want my reimbursement to decline. I'd like it to stay the same or go up. I think I'd want it to go up. Big challenge. Capital investment. Well, we're shifting capital, right? Because we got to shift capital where? To the community, because that's where That's where we need more capital. We need it in the community. We need to build some medical homes. We need to get all those community networks linked into so the ACO is all talking to each other. Well, capital, if the hospitals are running ACOs, they're not investing capital in their own operations. They got to invest capital in the community. We're shifting capital to the community. So a lot of challenges in figuring this out, and you can see a lot going on. Most providers do not want their fee-for-service revenue to go away as fast as it needs to go away to have real successful cost savings. And I think it's going to go away in kind of a dragging and screaming way. As group experiences increase, so I start my ACO and I'm operating and I get good cost savings and I get bonuses for 3 years, and now I'm at this level. I'm at a different level, right? I got out, all the low-hanging fruit is gone. I've managed my CHF patients, I've managed my diabetes patients, and I'm there and things are good. What do I do now? Well, in theory, to keep getting a bonus, to keep getting savings, I have to keep getting savings. If I'm going to get a bonus, if I'm going to get more money, I got to keep getting savings. So we may need some kind of transitional program here from reward-only improvement to maintain once we get to a good level. I don't think we're there yet, but I think that's certainly a discussion that needs to be had. Now, there we go. I want to shift a little. So we talked a lot about ACOs. As ACOs grow, they're growing rapidly, and basically what's growing along with them is integrated delivery systems that may or may not be ACOs. Why would this be? Well, because there's a lot of pressure on value-based purchasing, right? The government is saying do value-based purchasing. There's a lot of consumer-directed health plans and what those mean are health plans that have higher risk for consumers, and higher risk for consumers mean more challenging collections for providers. So if you're a provider, you're on that end, you want to think about getting some help, and then there's a lot of technology needs, lots of technology needs here. So IDS offer all these things that might help: integrated scheduling, maybe help with billing and collection, maybe shared coverage with increased patient access, technology assistance, help with the e-records and evidence-based care communications, market power and reimbursement negotiations, shared clerical staff, and pay for performance opportunities, a lot of quality and productivity. So here, as the system's integrating get bigger, if I'm somebody without a lot of capital and I'm trying to survive, I look at these systems and I say, wow, I could get some help from the big, larger players. I want to join. And so we have this merging and acquiring and affiliating that's going on. And the America's Health Insurance Plans trade group are a little nervous about it because they think it might drive up the medical prices. And they think it might result in additional cost shifting to families and employers with private coverage. And they might be right. Let's look. So hospital and healthcare industry is rapidly consolidating. We have 22% of physicians working for hospitals according to MGA. I think this was like in the end of 2012, and 65% work in a hospital-owned physician practice. So that's some consolidation. CMS is pushing for the consolidation because they're offering funding for ACOs, funding for e-health information to get all the information so that it can be transferred all over the place, and penalties for readmission, all pushing towards this affiliation trend. And some of the risks of consolidation. In 2010, CMS Office of Actuary issued a report that said 67% of the increase in national health expenditure is accounted for by price inflation. One big risk of consolidation in the industry is that significant mergers tend to lead to significant price increases due to market power. There have been a lot of articles published on that. They also lead to more self-referrals. They lead to lack of patient choice. And the consolidation right now is occurring at a very fast rate. So we still have fee-for-service prominent in the industry, but as the industry consolidates, the fee-for-service negotiation with the larger players tend to have more market power. So there's this problem that, at least in the short run, the consolidation of the industry without the fee-for-service structure changing at the same pace can result in an artificial cost increase or a real cost increase for reasons other than the cost of medical care. And I think that's all for me.
Thank you, Kathleen. Our next speaker is Michael Shopman. He is a senior partner at Kern, Augustine, Conroy, and Shopman. They are general counsel for the Medical Society of the State of New York, and obviously a very well-known healthcare law firm. And he's going to be speaking to us about the Affordable Care Act and what impact it has had on the physician community. I'm just curious, with a show of hands, how many physicians do we have in the audience here? Yeah, I think that one of our thoughts coming into this is that there have been some studies that show physicians are thinking that perhaps the Affordable Care Act is going to be repealed, or that it's not really happening, or there's sort of a little bit of a head in the sand attitude in many, at least many physician communities, thinking that perhaps if they just wait it out, it will go away. And I think the speakers that we've heard from so far today given us ample demonstration that that is absolutely not the case. Mr. Shopman is going to take us through the impact that physicians are going to have, what happened, give us a little bit of history about the act as it went back and forth, and then talk about what the impact is going to be on the practice of medicine from the physician's point of view. Mr. Shopman.
Thank you very much. Well, good evening. We'll jump right in. I know it's been an incredible program so far. I'll try and give you my biased perspective. I'll tell you right up front, I don't speak for Emblem Health, all right? If you don't like what I say, yes, I do speak for Emblem. So, but my point is, yes, it's a bias. It's a pro-physician. And I would actually change that as I've sat here tonight. I might say it's will providers. Let's use the general terms. I know we have other than physicians here. We also have, I understand, physical therapists, other providers. What I'm going to talk about can apply to anyone who is on the treatment side of this equation, who is the individual practitioner. So the question is, I thought of maybe even as the hour goes late to just stand up and say, will physicians survive, stay and say no and walk off and leave in a flurry? But of course you will, but we need to change, providers and physicians need to change how they do things. That's the first thing I want to say up front. I know that seems obvious as you've heard about all these changes, but too many times, as was noted, physicians are pulling away. You've seen the recent study that was done, a national study was performed on the general public. What did they say? 48% of Americans don't even know that this is the law. All right, Deloitte has done a study. If anyone wants to see it, send me an email. I'm happy to share it with you. Most physicians, as was noted, believe that at some point in the coming years, this is going to be repealed. Ladies and gentlemen, in my 28 years of practicing law, have you ever seen an enormous body of law as big as this repealed? It's only gotten bigger, stronger, more powerful. So I think those are naive perspectives. We have to change as providers and physicians how we react to this, and are we ready for it? And that's really what we'll go through the history a little quickly. I want to talk about what I would call a practical solution, a hands-on change you can make right now, things that you can do as a takeaway to change your practice and your perspective on your own. You don't need to hire consultants, but you need to be doing it immediately. So let's jump in. Very quickly on our slide, as you know, we've said the law remains intact. The efforts are actually accelerating. As you're beginning to sense, I found the timelines tonight to be fascinating. I mean, I've never seen the state of New York react this quickly or stick to their guidelines, their time frames, and they are, in fairness to them. They're hitting their marks. They're going to be offering this come the end of the year. So it's very rare that we see them accelerating curves as opposed to pulling back. There's an enormous push for this to be real and be real very quickly. The last bullet is really the one to emphasize. No matter whether we agree it should be here, whether we like the bill, we hate the bill, we're in the middle. The future of medicine is going to be dramatically different in the next 6 months, nonetheless the next 2 years. I would say, in my opinion, if anyone in the room can raise your hand and say, I can tell you what medicine is going to look like in 3 years, I think you are truly the brightest person in the room, and we'd all love to hear it. I don't think we can. What this is going to be is different. That we can guarantee, dramatically different than anything we have seen. If we're going to turn away from it as providers, as physicians, and we're not going to understand that, you're going to get lost in the shuffle. You're going to get pushed aside. You're going to get hurt in your practice and in your compensation especially. From my perspective, what does the ACA really do? It controls physicians more than ever before. And that was, I think, candidly, in my cynical approach, is that it was intended to control physicians more than ever before. Because one of the equations is what? That doctors spend too much money. That fee-for-service is a broken system where doctors have unbridled, unrestricted access to charge whatever they might want, obtain whatever they want, order whatever they might want, refer to whoever they might want. That was the perspective. And the attempt here is to come in and say, we're going to now control physicians in a dramatic way. And here's the other part. What do lawyers get involved in? Not only the carrot, but what do we spend most of our time dealing with? The stick. In this law are enormous powers for the federal government to discipline, punish, oversee, manage, regulate, restrict, whatever word we want to use. So in my world, in the world we look at risk management for physicians, this is the biggest risk I've seen in 28 years. Medical malpractice, throw it aside. Don't worry about it. Tort reform shouldn't even be talked about anymore. This is what we should talk about in terms of a risk to a physician's practice. Not whether you're going to be sued for a $500,000 that when you have insurance that's going to pay that and 20 other claims just like it. We have physicians who have been sued 30 times and still practice every day. If you violate this law in a dramatic, serious way, you will not practice medicine in the coming months. So, understand, again, it's unlikely to be repealed, as we've said before. I think that's a silly perspective. There are articles still being written on how to get the bill repealed. Can you shift Congress in the coming election and get the bill repealed? This machinery is too big, too large, and too far down the road. Talk about what are the control provisions. And this is really getting into my practical solution tonight. You've seen it in the slides that have already been talked about. What did you see consistently through almost every one of the speakers? Quality measures, performance measures, standards measures, quality standards are all going to be built into ACOs, integrated healthcare system, changes in even the insurance industry as they get into that business of managing medicine more aggressively. Well, we're going to have to set benchmarks, and you're going to have to meet those benchmarks, or you're not going to get paid. Let's throw aside the scary healthcare fraud thing, the shiny badges, all right, and the FBI agents and the IRS agents. You know that there's 18,000 new IRS agents being trained to come and investigate what? Healthcare fraud. They're not coming to investigate taxes. They're coming to investigate healthcare fraud. How many of you ever dealt with an IRS agent? They are the most horrible people you'll ever meet in your life. I don't care if they're your cousin, your sister, or your husband. Right? They are the worst people because they don't understand medicine. That's our problem with them. But coming back, it's not only that scary part. What about getting paid? How quickly do you get paid? How much do you get paid? When do you get paid in terms of the actual process itself? Are you getting paid in the front end or the back end? All of the standards that we've seen are already beginning to take place. Health insurers are now developing ranking systems. Are you a gold practice, a bronze practice, a silver practice? What does that mean? It doesn't mean you get a star or a different brochure. It means you get paid less, you get paid differently, or you don't get paid. That's what it means. So we have to understand coming into this, healthcare fraud and healthcare enforcement has been increased dramatically. The funding is overwhelming. Think back for a little ways. In 2008 or 2009, when this was being talked about, how were they going to pay for it all? Come on, remember, you were part of that debate. What did they say? When they said, wait a minute, we don't want all these big, new, scary taxes. How are you going to pay for this enormous body of law? Fraud investigations. That was the solution. Well, there's all this enormous fraud in medicine, so we're going to take the fraud out, therefore save all this money, recoup it to the federal government, and therefore we can pay for health care changes, health care reform. So in order to do that, the law had to be changed dramatically to give them new powers. You simply couldn't come in the door and say, we're now going to enforce what's already on the books. The law is changed. Civil monetary penalties has gone through the roof. And this applies across anything with the federal government today. Many of you have seen recently the reporting by the Office of Civil Rights for HIPAA violations. What are the numbers that we see? $250,000, $500,000, $750,000. I'll let you in on a secret about all of this, ladies and gentlemen. For the first time in the history of the United States, they're making money. They make it a lot of money. The money they invest in studies vary from across the round. Who does the study? From as little as $6 for every dollar they invest up to 23. So for the first time, they actually came up with an initiative that returns money in a dramatically profitable way to the federal government. In the changes in legal standards, and this is terrifying, I'll be candid. As an attorney, this is scary. You no longer have to prove to prosecute a provider, so it's any practitioner, you don't have to prove knowing and willful, meaning I took this money knowing it was wrong, I did it willfully, and I am now deserving of punishment. That was the standard that the government used to have to prove. No longer have to prove that. You don't have to prove knowledge or intent. The bar has been lowered dramatically to prosecute practitioners throughout the country for healthcare fraud. Triggers applications of very scary laws like the Anti-Kickback Statute, False Claims Act, all carry dramatic penalties. So, what's the increased scrutiny? It's not only at the big scary end, it's at the front end. When you as practitioners, be honest. I represented you for 28 years, all I've ever done in my entire career. When you're filling out credentialing applications, you're filling out initial paperwork for Medicare, Medicaid, private insurers, are you looking at it? I know this gentleman say no, he gets to read them over his career, I'm sure. You're not. We need to change that because a simple false statement on your application, all right, your initial credential or re-credentialing application can exclude you. Medicare now has the ability, CMS has the ability to suspend you on a summary basis, meaning just walk in and say, we found this, you're suspended, no payments, you're out. Can any of you survive without Medicare? No one can. The point is also then the suspension will trigger mandatory investigations by the state licensing authority, here the state of OPD or OPMC, and you'll be now investigated by state and federal authorities. So we have to understand that they're going to be looking much more at our standing, not just our claims and our billing, our coding, but where do we stand? What are we saying in terms of our credentialing? How are we in any way handling billing and coding? I'll let you in on a secret that most of the public doesn't know. What's the rough number? You think most practitioners in this country are billing correctly? The billers and coders who work with us, who represent practitioners, who work with physicians, will tell you it's between 68 and 74% of the time we're wrong. Not in criminally intending to steal money. We're not running some horrible mill down in Kings County that we were teasing about before you saw today's papers. But it's more we're doing it wrong because we don't know. And that's what I'm trying to get practitioners to change. We have to become as expert in this as our enemies are, as those on the other side of the table are. We have to become as sophisticated as they are in how to appropriately bill and code and, frankly, treat. Because if we're not, the standards have been lowered to discipline, to punish. And even if it's not a scary criminal case, if we're not getting paid, we're not surviving. And if we're getting paid less, we're not profiting. So the goal should be understanding that this is now a high-risk environment. We need to step up our actions. All right, as we said in the beginning, very beginning of tonight's program, public reporting of payments. Any payments. By the way, any of you work in New Jersey? Or in New Jersey, when you fill out your biennial registration, your application to practice, your license application, you are required to disclose this. And what they very cleverly did is they waited. All the doctors, did they disclose it? Come on, you're cynics, you're New Yorkers. Did they disclose it? Of course they didn't disclose it. None of the doctors disclosed it. And so what did the governor do? He subpoenaed the records from the pharmaceutical companies and then matched the two up. Remember, the governor is a former prosecutor. He's good at what he does. So he matched the two up, and now there's a massive investigation of every physician who failed to disclose that reporting. It's the same exact thing. So website is going to be available. By this year at some point, we're actually going to be able to look online. And every patient will be able to look online and see what monies have you received from a pharmaceutical company for any purpose at all, and how much was it. So this transparency, as was mentioned before, is a large part of this. Your world, practitioner's world, is going to be very open to the public. And I know what some of you are thinking, the public's never going to look at this. I disagree. I think the public's becoming more and more engaged. One of the most accessed websites in the state of New York under the Department of Health, the Physician Profile. One of the most accessed websites. Patients are looking at you as practitioners online and what are your credentials? What are your standing? Legally, federal government or state? I believe they will look at it more than ever before. So we must also have referrals and financial disclosures modeled after some state laws that we've seen over the years. You can't own hospitals. As we all know, physicians, a very famous case, not allowed to own a hospital, clearly sending messages to their bias as to the role of physicians in healthcare. Mandated compliance programs. Look at the last two. If you take nothing else from my talk tonight, I'm going to touch on that bullet point for a split second. Show of hands to the physicians in the room. How many of you, be honest, well, we are videotaping, but we're not seeing them, are we? All right, so you don't have to show of hands. I don't want to make it an admission. The national numbers would say the physicians on HIPAA and high tech, you complied with privacy. Did you comply with security? Be honest. Of course you didn't. 95% of the practices in America, the physicians and the practitioners in America, fail to do security, nonetheless do HIPAA or high tech. All of those, ladies and gentlemen, are the law right now. So if you take nothing else, back up, comply with security, comply with HIPAA and high tech, because you're headed towards that third bullet point, mandated compliance plans. As you know, here in the state of New York, Medicaid already has a mandated compliance plan. So we are headed under these models to where every practice, in my opinion, every practice in America will have a mandated compliance plan that you have to implement, adopt, and live by. So you can see that scrutiny, that oversight, that management is becoming more and more. So I wanted to talk about the practical solution. What do you have to do? What you say, Mike, what's my takeaway? What can I do now? I know 2 years from now it might look different. I know all of these things are going on. What can I do today to change things? The key word is one word, data. Ladies and gentlemen, if you don't have the data, I'm going to talk about that. If you don't understand your data, if you can't use your data, you're not going to survive in healthcare. Everything is about data. Now, how many of you have an EMR, work with an EMR? All right, only about half. All right, so those that aren't in an EMR, you should be moving towards an EMR because you'll need the EMR to give you the data that we're going to talk about. Those that are in an EMR, you have it already. It's built into the program software. You may not use it the way I'm going to talk about, but it's there already. You don't have to pay for something new. What is data? It's not just how much money you make. All right, how much do we charge? How much money did we make last year? Nobody wants that conversation, right? It's depressing because it's less. But it's more. For example, patient demographics. If you're going to apply for an ACO, you're going to seek to become part of an ACO, or they're going to credential you into an ACO, you're going to have to be able to sit and say, my patient demographics are the following. I have a high Medicare population. You want me. You want to take me into your ACO. I want to be part of that North Shore LIJ, ACO, and I want to be the only specialist. All right? So I can make a lot of money. That's the idea. But give you a quick example. Any of you watch these silly reality shows on television with the restaurant makeovers and bar rescue, and they come in and they change your business? Well, what fascinates me when you watch those shows at 1 in the morning, because there's nothing else on, right, is that they talk about, and many of you may have friends or family that own a restaurant. What do they talk about? How much do you make on every glass of soda? How many times do I have to turn this table to make money? What's the average tip that one of our waiters or waitresses should receive? What is the food cost for each item I plate? That's a restaurant, ladies and gentlemen. That's a bar that understands how many bottles, how many shots come out of a bottle and how much profit it makes. Can physicians do that? Can practitioners do it? Can they stand up and say, I need to turn my practice every patient, every 20 minutes, I need to be looking? You can't. It has to change. That's what we have to be able to do. You, practitioners, have to be able to do, is talk about, because you are going to have to sing for your supper. I hate to say that, but every one of these reforms, every one of these models that they're coming up with is built in one thing. If you want to get paid, you're going to have to prove to me you performed well. 33 quality measures, right? We saw the slide. It was put up a few minutes ago by the doctor. 33 quality measures. Can you stand here right now and tell me, Mike, I know all 33, I could hit every one of them? I dare say you can't. We need to change that. So patient demographics, outcome, prevention services. You saw the slides. A lot of the ACA is built upon, are you preventing disease? Are you managing disease? How many times have you spoken to your patients about smoking or smoking cessation? How many times have you spoken to your patients about weight loss? How many times have you spoken to your children that are part of the practice about weight loss and adolescent obesity? What are you doing to help them with that? If you can't talk about that as your own advocate, you're not going to get paid, you're not going to be brought into the ACO, and your payment structure is going to change negatively. So procedures and service analysis. How many times do you refer patients for procedures? Ladies and gentlemen, what's a code name for quality measures? All right, what does it really mean when somebody says, I want you, I'm paying you? Come on, where's my cynics? I am paying you. I'm taking money out of my pocket. I'm calling it quality. What does it really mean? Cost cutting, cost containment. You need to show me that you can cost cut. I saw slides by someone who was up talking about the structure of an ACO. I won't say who it was, large health system, and they came up with a new term. Are you a good citizen of the ACO? I never heard that before. So, of course, I'm a pain in the neck in the back of the room, waving my hand. Hold on. What does it mean to be a good citizen? What, that we coach Little League? I don't know what that means. And he said, well, and here was his answer, very open. He said, are you in or are you out? Do you keep it in or do you keep it out? Almost like a Dr. Seuss book, right? And he said, do you refer within our network? Do you keep it in our network? Or do you reach out the network? If you reach out, you're not a good citizen. So you see, the incentive is going to be, can you advocate that you're a good citizen? Can you advocate with data? It's always about data, that you can meet the standards that they have set. How many of you, when you walk out of a hospital today, what's the one thing you're guaranteed to get? Patient surveys, all right? Hospitals have been brilliant at this. God bless them. They've been hitting patient surveys for years. And when they walk into the health plan, what do they say to the health plan? 98% of our patients who use our services find us to be excellent or very good. 25%, all of these numbers come from patient surveys. How many of you ever used a patient survey? Okay, we have one. It's a couple. Patient surveys for practitioners, for physicians, you should do them tomorrow. Because you know what they all say? They love you. It's amazing when we get involved. They come back with letters that bring tears to your eyes. But yet doctors are afraid. I don't want anybody to talk about me. I don't want anybody to rank me, to rate me. Ladies and gentlemen, they're already doing it. So we need to be able to use that data, use that love and affection they have for you back to be able to get the last one, exclusive contracts. Can we advocate? Can we come into a hospital? Can we come into a health system and say, you should contract with me directly? Because we're better than someone else down the street. If you don't think this is going on, how many of you have heard of, for example, NAPA? It's a national anesthesia group. National. They walk into a hospital and they say, you have an anesthesia department, it costs you this amount of money, here's our data to prove to you we can do it better. Are hospitals hiring them? You bet your life they're hiring them. Because they come in, and if you ever saw a NAPA presentation, it's not about, it doesn't even get into the qualifications of the anesthesiologist. It's all about data, patient safety, patient outcomes, all of the things that they've been able to collect. So, surviving under the Affordable Care Act, we gather the data. You have to start to gather the data. If you want to hire someone in your practice administrator, your office manager, someone outside, I'd encourage not. I think the owners of the practice should understand their own data. We talked before, when we were talking about, there's a group out on Long Island, Allied Pediatrics, and the president of it, Mark Lashley, gets up very publicly and says, we have the data, and we understand our data, and I get paid more than you. That's his clear expression. He makes it work. Very bright young man, pulls the data together and walks into the health plans, walks into hospitals and says, we want more money, and here's why we believe we deserve it. Reviewing the data, it always changes. We know that. Data changes. Demographics change. Patient populations, reimbursement. We have to understand it. Right? And the physicians of this world are the brightest of all of us, so they certainly can understand data when it's presented to them and being able to present and advocate. Today's world is going to be all data-driven, medical data-driven. Can we present and use it as an advocate to win that better contract? You will get a better contract if you can sing for your supper. If you can't, you're going to be left on the side, or you're going to be forced to make bad decisions like joining a group you don't really want to belong to. Affiliating with a hospital is giving you a really bad deal, but because you couldn't advocate, you were forced to take it to survive. Seeking out performance and ranking standards. It's already going on in health plans. How many of you have seen the ranking systems that are now out? Physicians are being given correspondence that you have been ranked and you're a bad practice. Well, some of them good, I'm not trying to say it, but some of them are bad. Natural ranking is, if we have a race and there's three of us, somebody's finishing third. All right? Probably going to be me, but that's another issue. So the point is ranking standards are already here. What I want it to be is seek out your rankings. The health plans you work with, the contracts you have, what are your rankings now? Are we ranked? And if, ladies and gentlemen, it's adverse to you, challenge it and fight it tomorrow morning. Because that ranking has a snowball effect. If you're ranked negatively, patients will not come to you. There's a great study that was done years ago. They did a focus group for several years, very large international health system, health plan, did a survey, and they asked the patients, what do you value most in a practice? What do you think would entitle a practice to have a gold star, a bronze star, or a silver star? And there were 10 things that the patients came up with. What was not on the list? Quality of care. All right? It dealt with everything. It dealt with a clean restroom. It dealt with updated magazines, a working television. It dealt with a pleasant receptionist. It dealt with everything. All right? So the point was they came out and they said, well, let's rank physicians, let's rank practices, let's rank practitioners based on non-quality of care perspectives. And why did they do that? Because when they put the rankings out, who followed the rankings like lemmings? They just followed it wherever it went. The patients. Ladies and gentlemen, if I announce tomorrow you're a 1-star practice and you're a 3-star practice, trust me, people are going to you and not to you because of their naivete. They don't understand the nuts and bones of what should be a good practice. But because you've been given 3 stars, they're coming to you. So we have to understand that adverse rankings are not esoteric. They're not just, oh, who cares? I really don't like that insurance company anyway. They are part of our standing. So data is the key. If you want to survive in medicine under the Affordable Care Act or whatever it looks like in 3 years, I'd urge you, encourage you, begin to pull the data together, study it, analyze it, and advocate for it. You do that, you're going to be another Mark Lashley standing up and saying, I get paid more than you, and here's why. So very quick, all right? And I'm happy to, as I said, if you see any questions, if you'd like to see the Deloitte study, it just came out. I'm sure some of the panel members have read it. It's fascinating reading on exactly what the physicians think of the ACA and the future of medicine. So thank you very much, and we have questions.
Thank you very much, Michael. That was really very interesting. Maybe scary to some, but we all know that data is really, really important, and those practical tips are very helpful. Next, we have Tim Johnson. Tim is the Senior Vice President and Executive Director of Finance and Graduate Medical Education at Greater New York Hospital Association, and also the Executive Director of the Greater New York Hospital Association Foundation. Tim has expertise in GME and many other aspects of the healthcare system, and he's going to be speaking to us about patient-centered medical homes and covering some of the initiatives across the state and elsewhere in terms of how these patient-centered medical homes are coming together, what it's like to have one, see one, feel one, and be in one. Thanks, Tim.
Thanks, Jen.
Hi, everyone. Kathy and Jay talked a lot about the things that I would say in the Affordable Care Act that are going to require additional money, and Pam had talked about the accountable care organizations, which is the big behemoth that's supposed to save a lot of money. I would call the patient-centered medical home one of the smaller pieces that is really supposed to be saving money in the healthcare system, and some folks actually think of it as the bedrock of the accountable care organizations and others. So I think it's really important as physicians, as practitioners, as people in the healthcare community that we understand a little bit about what this thing is, what we're doing in New York State. A lot of it is riding on the success of this, rightly or wrongly. So I just want to take a few minutes just to walk through kind of what's going on with patient-centered medical homes. So what I have up here is the 2011 standards of the National Committee on Quality Assurance. The National Committee on Quality Assurance is viewed as the sort of gold standard for what a patient-centered medical home is. They put these standards together. The 2011 standards are an update of standards that were in place a couple of years ago, and they're actually working on new 2014 standards, which we expect to be out soon. And they have this way of doing it that they kind of grade a practice or a clinic or a doctor's office under 6 different domains. And I always tell when I speak to physicians, whether you're a primary care doctor or a non-primary care doctor, I think it's really important to understand what the domains are and what's involved in being a patient-centered medical home. Because if you're a primary care practitioner or a physician, a nurse practitioner, etc., you will be expected to be complying with these standards, expectations. And if you're a specialist, you should know what those who will be making referrals to you are going to be doing in order to really make sure that they're providing the best kind of practice that they can. So the NCQA has all these standards up on their website. I would encourage folks to just look at them, and I just want to point out a couple that are up there. The first one on improving access and continuity, the big one there as a means to save cost in the healthcare system is to have things like some system for providing after-hours access, and that is meant to address the issue that we know that there's a lot of folks who use the emergency department as for primary care because their physician's office is not open. So patient-centered medical homes are expected to somehow have hours that are in the evening, on the weekend, to be more, let's say, realistic with the way people come down with illnesses and not work like the way the banks used to work, where it would be Monday to Friday, 9 to 5, and how convenient, that's exactly the hours I have to be at work. And now we go by and we see TD Bank open on Sunday, and I don't know whether I'm the only one. I always think I want to call the police because there's somebody robbing the bank, and meanwhile they happen to be open 7 days a week because people need to have access to certain things 7 days a week. So I think this is the future, and this is what folks are going to be looking for. Providing self-care, support, and community resources to really help those who are experiencing multiple chronic conditions, have social problems, identify some resources in the community that might lead to better health care for themselves. Tracking and coordinating care. We have an expectation now that primary care practitioners are going to be tracking the referrals that they make to specialists. What are the results? Are you coming back to me? I want to be the home for you so that you're not just routinely going to see specialists and expecting that that's part of the way that care is supposed to be provided. And managing patient populations. This is actually a big one for a lot of practitioners and practices, hospitals, clinics, etc., really thinking about a population as opposed to individual folks who come to see you, but really thinking about it in terms of how do I look at a panel of folks and who has the most pressing conditions that I need to follow up on, track, make sure they're getting their meds, making sure of treatment adherence. All those things are supposed to be contributing toward a lowering of the cost in the healthcare system. In New York State, we actually have a really terrific patient-centered medical home incentive program through the Medicaid program. This was included as part of the New York State budget a couple of years ago, and it was intended to spur PCMH development. And so what happened in 2009, we had about 400 patient-centered medical homes in the state. Now we have about 4,000, the most of any state in the country. And by the way, that's more than twice as many as any other state in the country. So New York State considers this a huge victory for the state, for the Medicaid population, that they can actually access services from a patient-centered medical home. But they also say, and this is a quote right from the medical director at the Department of Health, having a patient-centered medical home, we're at the floor, we're not at the ceiling, so we really have to improve on this to really bring costs down in the system. Also, you will find that many of the commercial health insurance plans are also having patient-centered medical home or patient-centered programs in working into their products. WellPoint, Humana, United, Horizon. I don't know whether Emblem has one. I apologize if it does and it's not up there. We have a quote here from this report that came out in September, which I would encourage folks to look at if they're interested. Medical home expansion has reached a tipping point with broad private and public sector support. So we're here to talk about the Affordable Care Act, and those that were putting together the Affordable Care Act were well aware of a lot that was going on out there around patient-centered medical homes, and of course they wanted to spur some additional development, incentivize patient-centered medical homes. So I just want to highlight two, and then I'll turn it over to Joan to introduce my colleague David Rich to close out the program. This is an initiative of the Center for Medicare and Medicaid Innovation, that's the CMMI. And what this is the Comprehensive Primary Care Initiative, where what they're doing is paying a monthly care management fee for Medicare fee-for-service beneficiaries. And my recollection, I'm going to get this wrong, so I should just look it up. What they do is they risk adjust it based on the Medicare beneficiary, so it's anywhere between $8 and $40 per as the care management fee. It averages out to about $20 per beneficiary. There's 500 primary care practice sites in 7 markets, including the capital region in New York, participating in this. And then in the later years of the program, the practices get to participate in some shared savings. If they save money for the Medicare program, they get to actually have some of the savings. Similar to what Pam was talking about with the ACO, the shared savings model, this is the same thing just on a much smaller scale, to really see whether providing a care management fee and doing a lot of this stuff that we're talking about would actually bring down the cost for the Medicare program. The other one I wanted to mention is actually focused on the FQHC is federally qualified health centers. This is more focused on those centers and really having them adopt those standards of the National Committee on Quality Assurance. So what the CMMI is doing is paying a monthly care management fee for Medicare fee-for-service beneficiaries to really incentivize the practice, the federally qualified health center, to hit level 3, and to really, the NCQA program has various levels for being a patient-centered medical home. So what they want to see is, if we give you this care management fee per beneficiary, would that actually allow you to have enough money to really develop your federally qualified health centers to have a really robust system and meet all those standards that the NCQA has put in place. There's 500 sites participating across the country. And what they want to see is, on the second sub-bullet there, is simply, as others have been talking about, Jay talked about, Pam, others, about whether this is going to spur them to provide more coordinated care. What we all know is that the healthcare system is extremely fragmented, and there's a belief among a lot of researchers, policymakers, that if you start with the patient-centered medical home and make that practice the real driver of coordinating the care, you can actually reduce some of those referrals and need for specialists, hospitalizations, ER visits. I think there's some question about whether this will really work, but that's why it's an innovation program. We want to see whether these kinds of programs actually work. I think that, last thing I'll say is that, I observed that I'm from the Greater New York Hospital Association, and 3 or 4 years ago, when I would talk to clinicians, physicians, and others about patient-centered medical home, the first response from a lot of folks would be, well, where's the evidence? It's just another fad. I don't hear that anymore. I don't hear that, in that I think this has really, as the quote said, really reached a tipping point where folks are really recognizing that this is the proper way for any beneficiary, any citizen, to get care that they need. And so I think you're going to see more of the commercial insurance plans adopting this and really making it not necessarily an incentive, but really a requirement to really participate in their network. And you'll see it from Medicaid and Medicare also. So with that, I am going to turn it over to Joan to introduce David Rich.
Thank you, Tim. As a primary care provider in my practicing career, I really understand. I mean, it hits home what is trying to be done in the patient-centered medical home. Everything else feels a little fuzzy to me, even though I read about it and talk about it a lot. But the patient-centered medical home does, in a practical way, make sense. So I think that it's interesting that New York State is so much farther along in that regard. And certainly when I speak to physicians on a daily basis, they also, it resonates with them, the whole concept. So thank you for that overview. David Rich is the Senior Vice President at Greater New York Hospital Association, and he's responsible for its legislative advocacy as well as public and member communications. He's had quite a bit of legislative experience, and I do want to mention that all of our speakers have very, very impressive biographies, and we've summarized a little bit of each of theirs, and I have not done any justice to their incredible talents, but I didn't think you came to hear me talk about them, but rather to hear them talk about their subject matter, so please forgive me. David's topic is the impact on New York hospitals In this landscape of cuts, I actually work in hospital administration at this point, and this is the scariest part to me, and I'm very interested to hear what David's going to tell us.
Great.
Thank you, Dave.
Thank you, Joan. There we go. Thank you very much. What I am going to talk about is not so much everything everyone else has talked about is having a huge impact on hospitals as well, whether it's the ACOs, patient-centered medical home, bundled payments, all the other types of reforms that we're talking about. But here I'm going to talk just more about sort of the big picture impact on hospitals in New York. So first of all, you might all know the hospitals in the country, represented through their associations, strongly supported the Affordable Care Act and strongly supported it passing. And what's kind of funny about what I do is when I have to go and work with Republicans on Capitol Hill, they say, oh, you liberal hospital people, you all supported Obamacare. And it's not like all the hospital CEOs suddenly went crazy and became Democrats in 2010 and supported this bill. It's because it obviously makes sense. Jay said that someone had said to the health insurers, you traded more regulation for more customers. The hospitals basically traded less Medicare revenue for more covered customers, if you will. It doesn't take a rocket scientist to know that it's better for hospitals if their patients have insurance than if they don't. And so the hospitals in the country basically said, you know what, there's a lot in the bill that we have concerns about and that we don't particularly like, but the big idea in the bill, which was to provide more coverage for people, was something that hospitals simply could not oppose and needed to get behind and support. So we did. Now, as was mentioned before, the Affordable Care Act's goal at this point, or the estimates at least, is that it will spend about $1.3 trillion through 2023 to cover about 27 million more Americans. And the question is, how do they come up with $1.3 trillion to do that? It's through a combination of spending cuts and tax increases. Over half of the 1.4 trillion, and it's 1.4 trillion because they did a little bit of deficit reduction in there as well, believe it or not. Over half of the way they pay for it is through cuts to Medicare and Medicaid payments to providers. The largest savings of that comes from reduced scheduled payments to hospitals. And of course, the theory was that hospitals will benefit by having more insured customers, more insured patients. Their uncompensated care will go down, their charity care costs will go down, and the hope would be that over time, the cuts and the new revenues from newly insured customers will even out. And so at the end of the day, the idea was hospitals would sort of be in the same position, only they'd have more covered customers or more covered patients. So that was the idea, at least. This just shows sort of the breakout between the Medicare and Medicaid cuts and the new taxes and fees. And so what are the ACA hospital cuts? The biggest one, and some would argue it's not necessarily a cut, we call it a cut, but the biggest one is basically reducing the scheduled increases, inflation increases in your Medicare reimbursement rates. So if your Medicare reimbursement rate should have increased 3% in a given year because that's what healthcare inflation was going to be in that year, it'll only increase by 2%. And that's just an example. It's not exactly what the numbers are, but that's the idea. And so by doing that, Medicare will spend less over time than it would have otherwise and can take the savings from that and provide the subsidies through the exchanges, expand Medicaid, etc. So that's the biggest set of them. It's a reduction in your rate of increase, if you will. Then there were a number of cuts to safety net hospitals. Both Medicare and Medicaid do pay safety net hospitals more right now than other hospitals. On the Medicare side, on both sides they call them disproportionate share hospital payments, meaning you have a disproportionate share of low-income patients. And on the Medicare side, the theory always was that if you have a disproportionate share of low-income Medicare patients, your costs for caring for them are higher than if you had all affluent Medicare patients, because these patients are probably less likely to have been insured when they were younger. They may have less access to healthcare providers, they're sicker, they've got a lot more problems. There may be social issues as well that need to be dealt with. Some of them are homeless and lots of different issues there. So Medicare has always paid safety net providers more for that reason. On the Medicaid side, the states, for the most part, have given funding to hospitals, also safety net hospitals, to help offset some of the charity care that they provide and some of their uncompensated care costs. Never covering all of it, certainly, but providing some help. So the theory behind cutting these payments was that safety net providers will have a lot fewer uninsured patients, and so therefore the safety net hospitals probably don't need as much Medicare and Medicaid disproportionate share hospital funding once the insurance kicks in 2014. So you've got the inflation factors reduced, and then you've got these cuts to safety net hospitals. There are also some other cuts which people would view as quality-related cuts or penalties. Someone mentioned before the penalties for excess readmissions. So if your rate of readmissions for patients within the 30 days after discharge is disproportionately high, you have penalties that apply to your Medicare reimbursement rates. And then also there were cuts for hospital-acquired conditions and other reasons as well. Other ACA policies which can result in reduced funding for hospitals. Someone earlier mentioned value-based purchasing. What that means, basically, when this is fully phased in, this has started already, but it's not quite a 2% withhold yet. But basically, at the beginning of the year, Medicare will withhold 2% of hospitals' payments. Hospitals can earn part or all of that back, or actually even more than that back, depending on their relative scores on quality measures and patient satisfaction, which is why those surveys go out when you leave the hospital. As Michael said before, if you have a 3-person race, someone's coming in third. The way these scores and rankings work, there's always someone at the bottom. There's always going to be someone in the lowest quartile. It's all relative. There's some of it has to do with improvement, but for the most part, it's all relative. So it's very possible for everybody to start getting better over time, and yet you're still going to have people who don't earn any of their 2% back. So that is something that everyone's working on really hard right now. I think we're up to 1.2% being withheld or something like that. It will be phased into 2% in a couple of years. And then also major impact on hospitals from the delivery system reforms that have been talked about already. So what's happening to hospital revenues under Medicare is basically the blue line is if the ACA never happened, and you got all your inflation updates the way you would have had the ACA not passed, and basically your reimbursement rates would have gone up for hospitals about 44% through 2022. Instead, because of just the cuts, the inflation rate cuts, the disproportionate share hospital cuts and whatnot, it'll only be a 27% increase. So the 44% really is CMS's estimate of what hospital cost growth will be during that period of time, but Medicare is not going to keep pace with that. It's only going to increase your payments by 27% over that period of time. Then, if you also suffer all of the quality cuts as well, you don't earn any of your 2% back, you get penalties on readmissions, you get other penalties that are in the law, you could have your Medicare payments increase by only 17% through 2022 when your costs are growing by 44%. So powerful incentives to reduce your costs. And so really the big question here is, did the hospitals make the right bet in 2010? Will they really see enough new revenue from the uninsured to offset some of those cuts? Now, obviously, what everyone's supposed to be doing too is become more efficient so that costs don't really grow by 44% through 2022. And that's where the ACOs come in. That's where all of the different efforts to try and reduce hospitalizations come in. But even putting all that aside, the question is, will you be able to weather these cuts when your costs really are increasing, and probably still will increase faster than the reimbursement rates will? In New York, we think at least, it's highly unlikely that there really would be a netting out of the cuts versus the new revenue from the insured. And there are a few reasons for that. Kathy mentioned before that New York was one of the states that already had expanded its Medicaid program in some ways beyond what the ACA we thought required states to do. Now, states don't have to take the expansion, but far beyond the ACA expansions. And as she mentioned, the expansion alone in the income eligibility requirements is only going to cover another 70,000 or so. We do think there will be another 500,000, as Kathy mentioned before, who will be enrolled in Medicaid, people who are already eligible mainly, who now hear there's a mandate, even though the mandate doesn't really affect low-income people in the same way it will affect others. So there will be another 500,000, but we have 5 million people enrolled in New York's Medicaid program, so that's not a huge increase. Also, many hospital patients will probably remain uncovered. As Kathy mentioned before, we think 1 million people will gain coverage because of the ACA. That still leaves 1.6 million uncovered. Many of those obviously will be undocumented immigrants. The law says about 20,000 times that no undocumented immigrant shall get any benefit under the law. And so a lot of hospitals in inner city areas, but not even just inner city areas, serve a lot of immigrant populations and serve a lot of undocumented. And there will still be some for whom, even with the subsidies, coverage is unaffordable. We don't know how many, we don't know what that will mean exactly, but we do obviously live in a high-cost state, and so there may be some who can still get hardship exemptions and other exemptions that apply under the law. And so we really don't think there will be, as much as there may be elsewhere in the country, such a match between the reductions to hospitals and the new revenues. And the other problem we have is Congress keeps cutting hospitals. This is part of what scares you at night. They keep doing it over and over and over again to try and deal with, all of you who are physicians very well know that every year Medicare formula spits out a cut to doctors in their reimbursement rates, and Congress patches that for a year at a time. And when they do, they have to pay for it, and the way they often pay for it is cutting payments to and reimbursement rates for other providers, including hospitals. So that keeps happening. Sequestration, the 2% cuts, Pam mentioned that before. That's happening, and that's supposed to happen for the next 9 years. We'll see if that actually happens. And then also there's all this talk about doing a grand bargain on deficit reduction. And every time they talk about that, they say the biggest problem that the federal government has is Medicare. So we need to cut Medicare. And the hospitals are the biggest, get more Medicare payments than any other provider group. And so therefore, we're always at risk for more cuts there. So, some people had hoped that when the ACA passed, it said, okay, here's what's going to happen for 10 years. Here are the cuts you're going to take. Those are your reimbursement rates. Barely a year went by before they cut Medicare payment rates for hospitals even more. So a lot of concern out there about how hospitals over time, especially safety net institutions, will be able to continue to provide the care they're providing with major reductions in reimbursement and their costs still rising. So that's basically what I had.
Okay, so we're we're planning to have a panel discussion and time for questions, so I'm going to just ask the panelists to come up and take a seat.